All right, everyone. Well, welcome to MSGERC's fourth episode of our Grand Round series. Today, we'll be discussing community-acquired pneumonia, when to think fungus. So thank you all for joining us today. So my name is Dallas Smith. I am a PharmD, and I'm actually an Epidemic Intelligence Service Officer with the Mycotic Diseases Branch at the U.S. Centers for Disease Control and Prevention. I'll be serving as your moderator today, and we have two wonderful and very our expert physicians here today to help us go through some cases. We have Dr. Robert Bradsher and we have Dr. Gabe Vilchez with us today. So without further ado, I will also want to be introducing an upcoming tool that MSGERC, CDC, and also the coccidioidomycosis study group have been developing over the last few months. These are endemic algorithms that are focusing on improving testing practices with primary care and urgent care providers. So they're endemic algorithms that are looking at clinical diagnoses. We've developed algorithms for all three of our endemic mycoses: coccidioidomycosis, blastomycosis, and histoplasmosis. We are anticipating these to be launched in November of 2022. And we are hoping to have support through publication and also CME activities. So please be on the lookout for these tools that will hopefully improve testing practices so we can better understand these endemic mycoses. Next slide, please. So without further ado, I will pass it over to Dr. Gabe Vilchez.
Hey, thank you, Dallas. I love that your title is Intelligence Mycotic Search. I mean, it sounds like you work for the CIA or something like intelligence service. So I love that. So my name is Gabe. Bob and I were fungi experts, and I'm always going to use that joke that we're fungi experts. And then so far, this is my favorite webinar, not because we're in, Bob and I, but just because I love the term. I love the name of the webinar, and it's like when to think about fungus. And then I think that's going to be what we're going to try to do with a couple of very relevant clinical cases. We're going to try to develop a framework in which people, what is that scenario in which you should consider that the patient that is sitting in front of you could have a fungal infection? And then this webinar is for everyone who wants to learn, but I think it's providers are like nurse practitioners, family medicine doctors, internal medicine doctors, and even ID doctors are working in communities that are highly endemic. Then they're going to take a lot of advantage of like when to think about, oh my God, this could be a fungal infection. So this is like one of the cases that I had. I don't know if you know much about me, but I was practicing as an ID provider in a community hospital in Eastern Kentucky, which is in the Appalachian Mountains. And then I think it's an area that has not been investigated very well, but from my experience for the past year or so, it seems that it's a very hot spot for endemic fungal infections. And then this is a real case. I modified a few things. So make it very difficult or almost impossible to identify the patient. And then I'm going to just try with my experience going through the case to explain what were like the difficulties to make a diagnosis that I found in the way. And then I want to just like pay a few attentions about who the host is, what is the environment, what are the risk factors for the host, and especially pay attention to the tempo. I mean, how long it took from the beginning of the symptoms, start to make a diagnosis, what were like difficulties in between, and then and then how to and this is like mostly focused in an outpatient setting from my experience when the patient came to me. So next slide. So she's 47, and the name might be or not a hint of what the patient could have. Might be confusing, okay? So I just try not to. So she's a 47-year-old lady, and then she has no significant past medical history, and then she's like very healthy. She's a person who goes and do daily jogging or exercise at the gym. And then her symptoms started more or less about February. And the thing is like I'm going to present it from when I saw her coming from the back until the point I saw her. They sent her to my clinic 3 months after her symptoms started, right? So let's put this back in February. No significant past medical history. Just maybe hysterectomy. I think the maternal aunt died from breast cancer when she was 49. And then she started having dry cough and fatigue that persisted for 1 week, 7 days, 10 days. And then she thought she would have like, okay, maybe I have a flu-like symptoms. She already got her COVID vaccine booster. She already got her flu vaccine. And it's like, okay, let me just go to my primary care provider because my symptoms are not similar to previous respiratory viral infections in the past. They're lasting longer and then they're a little bit more intense and severe. So I thought, okay, that's fine. Just take 7 days of amoxicillin, just go home and then just let us know if something happened. Then her symptoms did not improve after 7 days. She waited like 10 more days or something. Just like, oh, maybe I need a little bit more time. Nothing happened. Her symptoms continued to be present. And then she went back to the PCP and then said, well, take 5 days of azithromycin. And then maybe this is an atypical infection. Who knows? So then she took those 5 days and then more or less 2 or 3 weeks have passed between her symptoms started going on and off the doctor and taking approximately like 10 days of two different antibiotics. So her symptoms worsened. She started complaining of subjective fever, intermittent fevers, night sweats, and she was having more cough related to pleuritic chest pain. So definitely 3 weeks, 4 weeks into her symptoms, she's not doing very well. Next slide. So this is one of the parts about like the epidemiologic diagnosis. So you're going to try to do a few things. You're going to like when you try to do work in diagnosis of something, you need to come up with, I think the way I see it, with a clinical syndrome. And then you're going to try to do an epidemiological diagnosis that is going to be in favor or not of what you're thinking. And then after that, you're going to try to decide which are going to be the best tests to prove your null hypothesis, if this is like something maybe fungal or there's something else. So asking questions like as a detective, pertinent questions are going to help you to kind of maybe sometimes get to the bottom of this. So born and raised in Eastern Kentucky. Okay, so if you see the map, you see that Eastern Kentucky might be a hotspot for fungal infections. She grew up in contact with horses. People from this area seldomly leave the area. And then if you go and ask, these are the perfect patients for board questions because they had been exposed to farm animals, they had been exposed to cattle, they had been, like hunting and eating jerky deer and all those things. So, but you ask the person questions. Okay, so she grew up with horses. I don't know if that helps you or not. I don't think it's a rhodocockus, but you start making your theories in your mind. She worked in a clerkship. Nothing very helpful in that. Her husband works in the coal mining. Okay, well, that's maybe something there. She had 2 healthy children, 2 healthy indoor German shepherds, and then she has never traveled outside the Kentucky, and she enjoys gardening in the backyard. She denies drinking any alcohol or using any recreational drugs. So a few things we can get from the social history. Next slide, please. So maybe now 2 months since her symptoms started, and she failed 2 lines of antibiotics that might be appropriate. For community-acquired pneumonia, she just went back to her PCP and then he said like, hey, I'm not sure what's going on. Let's do some blood work up and let's do some chest X-ray. Every time I just kind of like see these cases, I try to come up with a pattern recognition to see if there are things. And then, I just add in information in my mind. So white blood cell is 9. Her baseline is 5. Okay, there's something different. That's a year ago. Maybe some neutrophils, maybe some lymphocytes, nothing really predominant in there. Hemoglobin is 11.9. In the past, it was like 13 to 14. So it's like, oh yeah, there's something going on with the hemoglobin. Platelets, 600, when her baseline a year prior, it was like 300. CRP, 13 is slightly elevated. The sodium is borderline low, which was not that in the past. And the liver function tests are normal. And I think we ordered procalcitonin, which also was negative. So we are going to move to the chest X-ray. Next slide. So this is a chest X-ray. It's not the best quality because it's not an awesome picture, but then, definitely, I think you can see that there is a right upper lobe infiltrate, a consolidate there. That is, it seems like pretty dense. So, so far what we have, and this is the concept that I want just to get you, is this is like almost like 6 to 8 weeks of symptoms of a patient that, and this is a key term that you have to put in your framework. This might be seen as a non-resolving pneumonia or a non-responding pneumonia or a progressive pneumonia. And then when that hit your mind, it's like, okay, I have to open this box and try to think about other things because she got 2 lines of antibiotics. She 2 weeks passed and then no improvement. And then we don't have anything to compare if there had been any worsening or resolution of the chest X-ray, but we can assume that it has been there and it's getting worse. So non-resolving pneumonia, that's the point. What I'm going to do after that. Next slide. We obtain a CT scan of the chest. I'm just going to start with and then Bob and I talk about this. It's different a perspective. When you know so much and you see this so many times, then you do things automatically. But when I get to the case, it's like they ask me like, hey, Gabe, So you want a CAT scan. So how do you want a CAT scan? You want it with IV contrast or without IV contrast? And there's like, well, in this case, if I'm thinking about something fungal or cancer, I might just do the IV contrast because I want to see if the patient has some lymphadenopathy. So that's something useful. And this one was done with IV contrast. So you can see these dens consolidate there. You can see the next slide, I think, is going to show another picture. Well, that's a good picture. So that should be enough. So this is the question. So what do you think so far the patient could have? And then try not to think that it's just going to be something fungal because the presentation calls that it's a fungal webinar. So we're going to give some time. Is this tuberculosis because the husband works in the coal mine? Is this a non-resolving bacterial pneumonia because the patient might have MRSA, or very rare to be Legionella, or a multi-resistant bacteria for some? Could be breast cancer because she has history of breast cancer. Could be a fungal pneumonia, or it could be the terrible sarcoidosis that is in the differential for everything in someone of her age. I have the feeling that it's going to be fungal pneumonia. Okay, it's fair. And I think it's fair at this point to say that 31% and 44% for tuberculosis and fungal pneumonia, just because we're starting. We don't know. I mean, we need more data. And then TB is always in the differential for anything. Okay, we can do next. But no resolving pneumonia was then almost at 20%. And then, but then taking that it's a bacterial pneumonia, she doesn't have any risk factors, but however, we're seeing COVID-19 with MSSA, superinfection or MRSA. Superinfection could be this an abscess or an empyema or something that happened. We cannot rule that out. So we have something, we're gonna work on it. Okay, next. All right, Dallas, this is you, or you want me to go through?
Yeah, I'd happy to. So okay. These were these algorithms that I mentioned briefly at the beginning of the presentation. As I mentioned, they're not published yet, but we wanted to introduce them to this group just to make sure that we can get awareness out there. We wanted to create algorithms that were easy to use, especially for those who may not see fungal disease on a daily basis. And so I really want to take you through the right side of this slide, the algorithm for blastomycosis, because we just want to provide an example. So what we did here is that we outlined patients and areas where patients who have lived or traveled to may be considered to be tested. And so we have these maps that outline distribution in both the US and globally of areas where blastomycosis is known to be endemic. And then when we look at, and what we've seen commonly in literature and also in practice, is that patients often fail many rounds of antibiotics before being tested for a fungal disease. And so what we did was that if a patient lives or have traveled to one of these areas marked on these maps, and they've failed at least one course of antibiotics, we recommend testing this patient. Also, on the right-hand side of the blastomycosis diagnostic algorithm, we also have identified some initial presenting factors that you may want to consider testing a patient for blastomycosis if they have one of these, especially if they live or have traveled to one of these areas shaded in the maps. So for blastomycosis, on initial CAP presentation, if the patient has skin lesions or if a patient has a link to a known blastomycosis outbreak, we do recommend testing for blastomycosis and other mycoses as well. So Gabe, I'll turn it back over to you.
All right, perfect, thank you, Dallas. So I think after 3 months, so she still don't have an answer. And then I'm not quite sure if at some point she got a few days of moxifloxacin. I'm not quite sure. I think that's possible. So again, going to this epidemiologic diagnosis is like, I need to find some hints. Should I go to any history of TB or any history of exposure to someone who can have, make her at risk for multi-drug resistant if she works in a hospital? What kind of hobby she had? I mean, there are other fungal infections that are not endemic. For example, Cryptococcus, could this be Cryptococcus for some reason? So then you have to ask some questions. Like, I think, what is relevant? Is the patient is immunocompromised or not? Has she traveled? What is her occupation or hobbies? Unusual infections in people they know, or unusual infections in dogs, or other animals. And then next slide. I think I mentioned. Okay, can we go? Okay, so And then I'm going to go back to that point a little bit later when I see the patient and I ask those questions. So 2.5 months after her symptoms started, almost 3, patient was referred to the pulmonary clinic. So I haven't seen the patient just yet. And then they said like, okay, I saw the imaging. We're going to do, well, a bronchoscopy for BAL and transbronchial biopsy. And to be honest, at this point, especially after 2 weeks that they send bacterial, fungal, AFB stains and culture from the BAL, culture's came back negative, and then they send a transbronchial biopsy report like mixed acute and chronic inflammatory changes. At this point, we're just like, okay, could these be breast cancer? And then we're just kind of getting worried about that, especially the pulmonary doctor. So she was referred to oncology actually. So they have no, at this point, I think the next slide, I think they sent her to me. Can I see? Okay, so what happened is that she was having, through all this time, she was having dyspnea exertion, moderate exertion. She was having worsening pleuritic chest pain. So you can see that her symptoms were intensifying and becoming more severe and more frequent. Now she's having fever. Before they were subjective, she was like really tired. I cannot do anything. I can just stay at home. Next slide. Okay, so she was also complaining of all their symptoms: headache, weight loss, no sore throat, no neck stiffness, nothing other systemic. No similar, the sick context, and then she had the COVID vaccine, and then she was tested for COVID, which came back negative. She also had the flu vaccine. Next slide. All right, so this is what you get, and then what is your next step to make a diagnosis? And then if you're thinking that this definitely, as Dallas mentioned, is the patient that fits perfect in this possible workup algorithm, it's like, yeah, this is in the right area. It's an immunocompetent patient with a non-resolved pneumonia, and symptoms are worsening despite she got 3 different lines of antibiotics. This could be, if you think that this is a non-resolved pneumonia from an infectious origin, and then thinking that it's possible to be fungal, what would you do? Would you do any single then one of those, or would you do it all? And then we can just, after that, based on the results, talk to what are the different things that we can approach this. I think that's an excellent 66% mention all of the above. We can talk about some caveats, and then, Bob, just feel free to, if you want to make any comments or just jump in on this question and the answers. I'm just gonna give you my perspective is that, when you are the doctor sitting in front of the computer with any EMR that you have, and then you say, okay, this could be fungal. You sit down and you start typing. I don't have how to say it, an order set for fungal infections. So it's just a wide open, wild things that I can order. And then this is where I get a lot of confusion that, Bob and I and Alice were talking before this webinar, that something that is that, should I just order histoplasma urine antigen, or should I order serum antigen, or should I order both? And then should I order blastomyces urine antigen and histo? If I'm thinking about if this hist or blasto, should I order like, hey, she was not giving us any sputum, but can we do some sputum production? So try not to do an invasive procedure, and then send it for like a KOH or fungal stains and cultures, and then someone who I will trust can read it. And do I need serology, fungal complement, immunodiffusion, and ELISA? So you can order all those things. Those orders are available. The other question that you have to ask yourself is that, where is that test going to go? Is that test going to go to in-house, which rarely happens for histo and blasto? Is going to go to a referral lab, or is going to be to a referral lab who actually made the test? And I think there are 2 labs in the United States, at Mira Vista and in Indianapolis, and IMMY, or I think maybe there is something in Alabama, Bob, I'm not sure, that are like specialized lab for this. And then we're going to make a comment about this a little bit later. And then the other thing is, like, if you work in a community hospital, you don't see daily fungal infections. How much can you trust without being disrespectful? This is just a matter of experience. I mean, you haven't seen it much in a daily basis or very frequently. Most likely your microbiologists and your pathologists haven't seen it that often. So it's just, there is an observer variance based on experience. So I'm pretty sure, like, everyone who works with Bob included, they will recognize blasto in second. But then other people will think that in the micro or in the pathology that, I don't know, they could miss the presence of a yeast. Next slide, please.
Hey, Gabe,
Yeah, go ahead,
can I just
Yeah.
mention about the urine antigens? We tend not to get serum antigens, but would get urine antigens. And it's a common fungal antigen. So a person with blasto might well have a urine histo antigen that's positive. A person with histo, in fact, more commonly has a blasto urine antigen that's positive. We don't find quite as much help for fungal serologies, but I know a lot of institutions and a lot of ID doctors still do that. The rates of prior histoplasmosis in Arkansas is about 70%. So we don't find that quite as helpful. Some of our faculty recently did a study comparing a commercial lab that's not Mira Vista to results from Mira Vista. And for disseminated histo, the results were 86% were positive from Mira Vista and only 50% from a different laboratory. And Mira Vista is the one that was the first to do that. I have no conflict of interest. I have no interest in Mira Vista other than a friend of the guy that started it. But that's where we got our labs to not send it to the other fungal diagnostic labs, but to send our urine histo and blasto to Mira Vista. In fact, I think Mira Vista is the only one that does a urine blasto.
Yeah, that's a good point. And then no conflict of interest either. But that's one of the points that we thought when we discussed about this webinar that might be important to establish if you're seeing or suspecting that there are fungal cases in your community, that maybe if it comes back negative and you really suspect that, maybe you can repeat the test in 4 weeks or 6 weeks, but then that time maybe just consider to ask your lab to send the test to Mira Vista, because we have seen anecdotal cases, and I didn't know, I wasn't aware that about that study, that there is a difference between the diagnostic sensitivity or specificity if this is done by a not necessarily referral lab. Again, just to emphasize what Dr. Bob mentioned is that I think the only lab that does blastomyces urine serum antigen, urine and serum antigen or urine antigen is Mira Vista. There are like many different form of antibodies, fungal complement fixation, immunodiffusion, and then ELISA. And then I think ELISA is not widely available there. I think we need more evidence, just to be clear. For blasto especially, we don't have a lot of evidence. I think a lot of the evidence for fungal infection come from histo, and a lot of that population was based on patients living with HIV. So, you know, you're gonna see some variants, and then, but I mean, personally, I got really confused about when to order antibodies and then which specifically one, and then should I get the most specific one that is the bad one or the blastomyces adhesine 1 antibody. I don't think I have that access in my lab, or at least it will take me a lot of time to figure it out. So, you know, I guess one of the things that I would mention here that I think we remove one of the questions is like, I think it's always wise to rule out HIV/AIDS. And then that will be something that I would add to all the above. Is just mention, maybe rule out the patient does not have any other form of immunocompromising condition, especially HIV.
Can I make one more point, Gabe, before
definitely.
we go on? That with coccidioidomycosis, the fungal serology is very helpful.
Mm-hmm.
There can be cross reaction with the histo urine antigen, but it makes the diagnosis most of the cases of coccidioidomycosis, other than culture or smears.
Yeah, it just stands
alone. I guess we ought to move on quicker here.
Yeah. Dallas, all yours.
Perfect. Thanks, Gabe. So as Gabe mentioned, we created these algorithms. We presented some of the criteria for testing, or some recommendations we had for testing individuals. And then we created some of these algorithms that actually take you through maybe what tests you should consider first, and then what happens if they're positive versus negative. I just want to give a caveat. These are just tools that we want to provide to primary and urgent care providers who don't see these fungal diseases every day. And so this isn't the end all be all. We just want to provide guidance for them, just to, like I said, improve testing practices and make sure that we cut down on all these patients who are being diagnosed 3-4 rounds of antibiotics later. And so what I'll focus here on the right side again on the blastomycosis algorithm. And so initially we recommend having a provider order an EIA urine antigen test. And then if that is positive, we're going to assume probable acute pulmonary blastomycosis. If that antigen is negative, there's a couple different routes we can take. First, we can always consider alternative diagnoses, and that should always probably be in the back of all physicians' minds as they work up patients. If a high degree of suspicion remains, we do recommend to retest. And to retest, of course, we can do another EIA urine antigen, or we have some other tools in our tool set that Gabe and Bob mentioned before. So we can do a BAL and culture it. We can do a skin biopsy if a patient is presenting with skin lesions. And those serologic antibody tests, which Bob mentioned, aren't, sometimes they can be useful, sometimes they aren't. They might be good, especially if you're considering retesting, to maybe utilize that diagnostic tool. And so if one of those tests come back positive, we also will assume probable acute pulmonary blastomycosis. If those are negative, we can consider alternative diagnosis, but you can always revisit this algorithm if a high degree of suspicion remains. So Gabe, I'll turn it back over to you.
All right, thank you. I'm just gonna speed up a little bit. So I saw her, and then one of the things that I just want to mention is that when I talked to her, it's like, hey, any risk factors here and there, and it's like, I had to dig in. I thought you imagine something that is somebody who's going to be forthcoming. It's like, yeah, I have a family of bats, BATS, living in the attic, and then I feel really bad about them, so I'm not going to get rid of them. I mean, I'm just trying to clean it up a little bit, but I have a family of bats, a bat cave in the attic. And it's like, okay, that's fine. That's perfect. I think I know what you have. This is a fungal infection. Could this be crypto? It could be something else. And then I send the histo, serum, and urine antigen to my reference lab, and it came back negative. And that was a huge boomer. It's like, okay, this is breast cancer day. I was convinced. I was not that experienced at that time. So it's like, well, we have to get the bottom of this. So we proceed with a CT guided biopsy, a lung biopsy, and a PET scan, just working out for the cancer. And then this is just almost like 3.5 months. Just a picture. This is a beautiful picture because we usually don't get PET scans for fungal infections, but this is like really, really suspicious for highly metabolic activity. And then the thought of breast cancer was still in our heads. And then she had breast implants. So that made it difficult for the mammogram or the ultrasound to just completely rule out that she didn't have a mass or something in the breast. Next slide. So we did a lung, not a right upper quadrant, but we did a right upper lung biopsy, and the report was non-Caesarean granuloma. We sent it to the pathology lab, and then my pathology lab, they said like, oh, there's nothing in there. There's no cancer. There's like GMS and F15 are negative. So we learn, and then this is also maybe a teaching point, is that not be afraid or embarrassed or hesitate to send the tissue or for a second opinion. And then we send it to another specialized center for lung pathology. And then actually before they gave us their final result, they called us over the phone. It's like, hey, we're seeing large yeast structures. And then there was no any further description that was given to us. And it took this, one of the gold standards is always going to be the culture. It took 6 weeks after the BAL to finally report the growth of blastomyces dermatitis. And then no one mentioned that it was seen in the KOH because my micro lab is not expert in this. And then the cultures are sent to another lab. So next slide. She got really sick. And while we're working up this diagnosis, it's almost 5 months into the diagnosis. So she had to be admitted to the hospital. And we started having an amphotericin B. We gave her liposomal amphotericin B for 7 days. And then we transitioned to itraconazole. And I think the next slide is going to say that she started feeling, it's a slow process. She started feeling better only after 3 months of itraconazole treatment. And then after 6 months, she started going back to her baseline, and then the treatment was continued. And for another 3 or 4 months, almost like 12 months. And then we repeat the CT scan. And one of the other important things I'm just going to leave there is that she always going to have this, at least a year follow-up CAT scan after the treatment. She still has a scar in the lung parenchyma where the consolidation was there. So just to tell her that, hey, let everyone know that you're going to have that there, so they don't get confused that you have a pneumonia. I think that's it. Next slide. All right. Any questions? Anyone want to jump in?
Yeah, so we have a few questions from the chat. And so Dr. Alobaid asked, cross-reactivity, positivity, and urine antigen tests occur. Does it really matter? Isn't the treatment should be the same? Any thoughts from Bob or Gabe on that?
Well, it's exactly right that we would use the same antifungal therapy the majority of the time, maybe some nuances between histo and blasto in terms of fluconazole or itraconazole or posaconazole, but we'd like to know what it is. And so it wouldn't matter for that early therapy, but we'd like to know. There was
Definitely.
also a question about previous COVID. Gabe mentioned that she didn't have COVID. And histo and blasto haven't been found as frequently as mucor or aspergillus or even cryptococcus, but certainly could. And I'll mention about fungal histopathology when I show my case.
Perfect. So we'll save that for the next case. And then Bob and Gabe, I think Bob, you might have some experience. Any thoughts on the fungal PCR test?
Yeah. So
Yeah.
Excuse me. Our pathologists send a blasto histo PCR to the Mayo Clinic, and those come back. And sensitivity may not be quite as good as the culture. I mean, it just takes a few organisms to be able to grow. It may take a long time. So when it's positive, it's really helpful. But so is the KOH smear. And Gabe made the point, and I would like to underscore it, of telling the micro lab, I'm thinking this might be a fungus. I'm thinking this might be blasto or histo, if you could really look for that. And that helps them to be able to focus on that.
Perfect. And Bob, this might be a question for you, and this might be more of a lab question, but I'll ask it anyways. Do you know the best culture medium for growing blastomyces?
Yeah, ours is typically done in fungal media, and I'm not sure exactly what Sabrods, I guess, but it's done in the mycelial phase, and then it gets converted to the yeast phase. So these are endemic mycoses, meaning that at room temperature and nature, it grows as a mycelia, and that's when it infects people, and then it converts at body temperature to a yeast phase. That makes it a dimorphic fungus.
Great. And then a next question that I can actually answer a little bit too. The CDC published a report looking at the number of pulmonary fungal infections during COVID. And so I can definitely share that in the chat in a little bit. But I guess Bob and Gabe, did you notice that your facilities or your institutions an increase during COVID-19?
Ours did. Our mucor invasive fungal sinusitis went up. Our pulmonary aspergillosis went up. I don't know that we've recognized as much crypto, but others have made that association.
Yeah, no, my center, it was really bad for the past year, and then I got 2 blasto that was diagnosed post-mortem, and then I had like maybe 4 or 5 crypto cases related to COVID-19 that I shared with Jeremy Walker. So and then aspergillus and mucor, all that you can imagine. But I saw 2 cases of blasto that were very, very difficult. Nothing was coming up, and then actually the diagnosis was made 6 weeks after the patient unfortunately passed, when the cultures came back positive for blasto, and she had multiple cavitations in the lungs. It was really impressive.
Great. And I actually had a question of myself. So thinking about, we diagnose the patient, we get them on the right treatment, but there's that next step of therapeutic drug monitoring. And I know, Bob, you're at a larger facility, and Gabe, you're at probably more localized facility. I'm curious if you could talk about access to getting some of those levels for these drugs, and any barriers that you may identify at any institution, I guess, across the United States, and how important it is for therapeutic drug monitoring.
So for me, most of the labs are stand out. And then when I start following these patients and starting on treatment, I didn't have an open pathway to, there was not an order set for me to order itraconazole levels. So I have to write it down in a paper, and then to give the paper to the patients, like, hey, you have to do the trough level, take your last dose the night before or whatever. And then, but after I established that with the lab, then they just incorporate that on my capacity in the EMR to order that. And then after that, I have no issues. I mean, I was following isocortisol levels, and sometimes, I mean, I was following blasto levels also, the blasto antigen in a patient that was not responding despite being on appropriate level of isocortisol. I was able to do that after I opened a path, just like I want this sent to not conflict of interest to Mira Vista. I don't want to deal with your lab, just send this to Mira Vista. And then after I opened that path, after I made a few mistakes in different patients, and then I had to struggle. And that's kind of one of the points. You need to open this conversation with your lab.
Great. Thank you so much, Gabe. And I think we'll save the rest of the questions to the end of the presentation, but now we'll move over to Bob's presentation and let him present his case. So Bob, I'll turn it over to you.
Okay, thank you. So I saw this man a few years ago prior to COVID. Next slide. He is 43-year-old when I first saw him, that had really no past medical history. He had onset of cough and fever along with his family about 6 months before he sought care, when he had a chest x-ray that showed a mass-like infiltrate. He had a CT that showed a spiculated mass. He was given azithromycin and ceftriaxone, but his fever and sputum production didn't go away. So he was then sent, because of the radiology report, to a cancer center to try to make a diagnosis. Next slide. Socially, he was a smoker. He occasionally used alcohol, no illicit drugs. He was a supervisor of a federal waterway on the White River in Arkansas that dealt with construction and maintenance of the waterway, which included removing vegetation and trees and even dead animals from intake at 3 different dams that they had. He also told me that beaver dams were not infrequently found, and the crew would blow them up with dynamite or use heavy equipment to maintain the water flow. Next slide. So here's his CT scan showing a 5 by 4 centimeter mass, and he had a percutaneous biopsy performed. At the same time, the chest x-ray showed a erosion on his rib, and after that, they remembered, oh, I think I saw something on his nose that had been there for about 4 months. Next slide. So he had the bronchoscopy and biopsy performed. A lesion was noted. Next slide. And here's the lesion on his nose. It shows this verrucous lesion that if I just touched it with a Q-tip, exudate would come out. And he said that sometimes he noticed a smell of dead animals whenever the pus was present under his nose. He also told me when I saw him at this point that he had blood in his ejaculate and had some discomfort in his rectum. And on my prostate exam, it was enlarged and boggy. And I think he had the organism in his prostate as well. Next slide. So Dallas, you want to talk about this? You've already actually kind of said things about it.
Yeah, I think we can just go over it real quick. So just based on what Bob said, this patient would definitely meet the criteria to use this algorithm to test for blastomycosis or even histoplasmosis at this point. But I won't have to cover those again. So Bob, I'll turn it back over to you.
Okay, next slide. So I took a KOH smear to our microbiologist and looked at it with them and saw broad-based budding yeast and had a confirmed diagnosis of blasto. It also grew the organism, and with blasto, unlike candida or aspergillus, which might be a contaminant or a commensal in the mouth or oropharynx, if you get a culture that shows blasto or you've seen it, then you've got a confirmed diagnosis and it needs to be treated. Next slide. So here's a question. I know what I would use. So 50% or so said itraconazole, 5% said flu, 10 bori, a few savuconazole. Nobody said posaconazole, and 33% would use liposomal amphotericin. So I did use itraconazole in this man, and he did very well with it. Next slide. So within 2 weeks, when I had him come back to see me in clinic to get a level for his itraconazole level, he said that the lesion, and a picture of it showed improvement in the verrucous lesion that he was having. He was not having as much shortness of breath, and the itraconazole cleared both the skin and the lung lesions. However, on that visit, on the next visit, which was about a month after that, his diastolic blood pressures were elevated. He had some pedal edema, and he had a hypokalemia. And I got a itraconazole level back that was elevated to the point of here's a point about the serum levels that most commercial labs now that do it, which is where we send ours, do both the metabolite and the parent drug. So hydroxy metabolite and the itraconazole, and you add those together to get both of them are active. So you add those together, and his was 4.2. I decreased the itraconazole from 200 milligrams twice a day to 100 twice a day. And his potassium came back up. His blood pressure was better controlled, and so he was cleared. Could we go back a slide, Lisa? Could we go backwards one slide? There. So the latest guidelines that are out for management of blastomycosis is 2008. When itraconazole was recommended for people with mild to moderate for severe blastomycosis, somebody with ARDS, somebody that's intubated, then liposomal amphotericin would be the choice that was recommended. And then other agents might work. There were trials early on. There have not been any head-to-head trials with itraconazole versus other azoles. Mm-hmm. But there were some other trials looking at fluconazole, and it didn't appear to be as good a drug as itraconazole. I had some patients that developed new lesions while they were on fluconazole at high dose in those early trials, and then switched to itraconazole, and the lesions melted away. Let's go forward 2 slides. Oh, I'm sorry, go back to the itraconazole slide. There we go. So Sporanox is the commercial product of the capsule and the liquid. The capsules are not well absorbed without gastric acid. So I usually tell patients to take it on a fatty meal and take it with cola, Coca-Cola. Sometimes they'd ask me, is Pepsi okay? And I go, yeah, probably. But if they required a PPI or a H2 blocker, then they might need to take the liquid itraconazole, which is absorbed without acid. That would be given on an empty stomach. But I had patients tell me it tasted terrible. It tasted like dirty socks. A newer product called Supra bioavailable itraconazole was studied by the mycosis study group. That trial's finished. It's better absorbed, but I understand from the mycosis study group meeting a few days ago that the company has disbanded its workforce, and it's not clear that it's going to be available. I've not used it. I mentioned the negative inotropic effect that can occur. Let's move forward. Next slide. Next slide. So the clinical manifestations, one of my former residents said that it's a pneumonia unresponsive to Keflex, next slide, or a rash unresponsive to prednisone. And it really, I call it the endemic mimic, because it rarely is diagnosed initially as blasto, but it's thought, like Gabe's case, to be breast cancer or other kind of illnesses. So let me just give a couple of points about it. It starts with pneumonia in the vast majority of cases. There have been a few cases of cutaneous inoculation, but the majority of those, if you got a chest x-ray, they'd have a lesion there. So just like my guy that had the skin lesion, but he also had pneumonia where it came from. And it can present just like pneumococcal pneumonia with fever and chills and pleurisy and cough and sputum and infiltrate, or can have an appearance that looks more like cancer or tuberculosis with weight loss and night sweats and cough and hemoptysis. We have a number of patients that come in for a diagnostic bronchoscopy thinking they're going to have lung cancer and they have blasto diagnosed. Next slide.
Yeah.
So here's a lady that had what looked to me like a pneumococcal pneumonia with her left lung infection, and she didn't respond after 3 or 4 days of back then penicillin. And so we looked at her sputum and saw blasto and gave her, I think she got ketoconazole, which is not recommended anymore because of toxicity. But she quickly regained her 30 pounds that she had lost back up to her baseline of about 360. We grow them big here in Arkansas. Next slide. A baby that was born to a mother that had a vaginal lesion due to blasto and had massive ARDS and succumbed very quickly. So ARDS is a picture that can be seen with blastomycosis. Next slide. And in the old days, when there were TB conferences, if we would throw this x-ray up on a view box, then all the old heads would go, yep, that's TB. It looked just like it, but it was blasto. Next slide. I'm going to skip this one. Next slide. So extrapulmonary blastomycosis occurs in about half the cases that have been referred to me. Some with pulmonary infection, some after the pneumonia has already gone away. And the more common sites of dissemination would be the skin, the bone, and the prostate. But essentially, any organ could be could have blasto found. Next slide. And the lesions typically look verrucous or ulcerative after the top of the warty-like appearance has gone away. That the one on the right is a punch biopsy site next to the ulcer, and you can see the exudate in the base of the ulcer. And if I were to press on that verrucous, that 5-centimeter verrucous lesion, I would be able to get exudate to culture and to look at with a KOH smear. Next slide. Another example of a verrucous with a satellite lesion on a man's lip and on a patient with HIV and AIDS, not much inflammatory response for these ulcers on his lower leg. But even still, even without pus, if we were to scrape that ulcer, we would be able to culture and find the organism. Next slide. This lady had a lesion in her bone that kind of went all the way out to her skin, allowing the diagnosis. Next slide. And 3 different kind of skin lesions. One on the upper left is a man with that lesion in his nares, and that was the only site he had blasto, but it was seen and cultured. The man with the lesion on his buttocks hid it from his wife for a couple of weeks, couldn't hide it any longer, and he came in and was seen and had blasto diagnosed. And the larger picture of the man with the lesion on his nose was was seen by the head of dermatology at I won't tell you which medical school, but one in Dallas. I guess there's just one medical school there, but diagnosed keratoacanthoma, and it wasn't until he had new lesions on his leg that he had the diagnosis of blasto made. So it really is, it looks like other things. Next slide. Can go fairly uncommonly, but can go to the CNS with either mass-like lesions in the cerebrum or meningitis, adrenal insufficiency, GI tract, larynx. We had one patient from this institution that had a laryngectomy thinking that it was laryngeal cancer before. Even a couple of cases of otitis media that were due to blasto. Next slide. So a lot of different diagnoses that could be made. Lung cancer, bladder cancer. The man with the humerus x-ray was a truck driver, and he could almost not turn his truck all the way that he wanted to. A lady with a lesion in her breast that was thought on mammogram to be breast cancer. A lady that one of my former fellows diagnosed with thyroid cancer. You can see the circle around the right side of her thyroid gland. Misdiagnosed as tuberculosis, as sarcoidosis, a lot of other diagnoses. So blasto is often not diagnosed initially, and only when you really keep pushing at it and getting the urine antigen following that algorithm that Dallas has mentioned a couple of times. Next slide. The diagnosis is by seeing the organism or by culturing it and telling the lab, hey, I think it might be a fungal infection is useful. For us, serology is not helpful for blasto. Like I mentioned with coccidioidomycosis, it's the mainstay of diagnosis. There's not a skin test for blasto any longer. There was one early, and the urine antigen is available, and I think it is helpful and useful, and can be followed over time to monitor their progress, unlike crypto antigen, which can remain positive at high titer for a long period from the dead fungus in the CSF. With histo and blasto, the urine antigen usually declines over the treatment time. Next slide. And in my patient's urine antigen was negative 8 months after he was treated. So a KOH prep, a potassium hydroxide that will destroy the mammalian cells and leave in the broad-based bud of blasto, two different, one with the daughter bud and another one there. And then on somebody asked a question about histopathology, and so blasto can be seen with the H&E stain, but it has to be thought of and looked for, and somebody has to have recognized it. There was a case at Vanderbilt right as I was leaving my fellowship of a patient that had a lesion that a H&E missed the diagnosis, had a subcarinal lymph node that ruptured into the trachea, and the patient had died with ARDS, like seen on the bottom slide in that baby, that neonate that had blasto with the methenamine silver and a different magnification, kind of filling the alveoli there. Next slide. So that was my case of a mimicking diagnosis.
Perfect. Thank you so much, Bob. And I see we have a lot of questions coming into the chat, but I just wanted to add that these cases demonstrate that blastomycosis can be very severe. They can be disfiguring, and they have a pretty high mortality rate for a fungal disease. And so it's important that we diagnose these early, ideally in the primary or urgent care setting, so that Bob and Gabe don't have to handle these like intense cases. So that's what these algorithms hopefully will do to help testing practices and keep and hopefully decrease the amount of severe cases that these two fungal experts see in their practice. But let's go ahead to the questions. And so I'll answer the first one. Blastomycosis is a disease that's caused by fungi from the environment. And so dogs aren't sources of these fungal diseases. However, what we've seen is that sometimes dogs, if they're diagnosed with blastomycosis, that may inform that the patient should be on the lookout for blastomycosis as well, just because they're probably going to be exposed to the same environment. They go on walks together. So they can't get it from dogs, but if a dog has it, the patient should be aware of that. There
was a good article saying that canine infection is a harbinger of human infection. So asking, have you had a dog die? And they say, yeah, then that can be a real clue.
Yeah, perfect. And then my next question is from Monica, and this is for you, Gabe. Could you clarify why you recommend itraconazole trough concentrations in your case? My understanding was that because of its long half-life, once steady state was reached and the random concentration was adequate. Thank you.
Yeah, no, I think Monica is absolutely right. I think for me it's a matter of style and then how I do it. But I think after you reach that a steady concentration, I don't know how you do it, Bob. I just still do trough levels because I'm just used to it. But I don't think you necessarily have to follow that strictly like we were doing it before. So I mean, she has a point.
Yeah, I think that's right. So after 2 weeks, then there'll be a adequate concentration. Voriconazole might need to be tested earlier than 2 weeks, though, because of different pharmacokinetics in that. Posaconazole also should have levels drawn and followed.
Great. Thank you both so much. The next question that I have is, I guess Bob or Gabe, have you ever used a combination of itraconazole and amphotericin B together?
You know, they have the same site of activity in the fungal
Yeah.
cell wall, and so there was concern that perhaps they would be antagonistic. A
Antagonistic.
study in a different fungus with Canada showed that there was not a antagonism with azoles and amphotericin, but we've not done that. I might give the loading dose of itraconazole as I was finishing the Amazome, but Amazome is a stronger agent than the azoles in my experience.
Yeah, no,
Great.
same. I use, I think amphotericin B is like, as you mentioned, there might be antagonistic. One, the azole is trying to prevent the formation of the wall, and the other one is just making holes on that wall. So I think if they're not antagonistic, at least maybe they're not helping each other. But there is the possibility of antagonistic effect.
Great, thank you both so much. And this is a really interesting question. Have either of you seen a patient get a recurrent case of blastomycosis?
Yes.
And the next question is there any protective antibody effect of having previous infection for blastomycosis? So I'll throw it out to both of you.
I think there's more evidence of cellular immunity being effective. Some long time ago, we did some studies looking at lymphocyte transformation with a blastoantigen, and people that have had blasto continue to have cell-mediated immunity to it. The first part of your question, though, was what?
The recurrence.
Yeah.
If you have seen recurrence of blasto after you finish.
Oh yeah, I've seen relapse of blasto, particularly in HIV-infected patients. So it can occur. I don't know of a second infection. I haven't had that, but clearly can have relapse in a different location. So.
Yeah, I know. I agree 100%. I think I have seen 1 or 2 relapses, and then I think definitely is mediated by the immune system. And then there are so many immunodeficiencies or very point immunodeficiencies that we don't understand very well that can just make someone more prone, an immunocompetent patient, to have persistent blasto. And then also I had a patient that I was talking to Bob the other day, is that it had more like a immunologic reaction that to the blasto. So it just kind of like developed some like a pyoderma gangrenosum that looked like the skin lesion was coming back. But I think it was more like an immunologic phenomenon from blasto. But yeah, relapses are possible.
Great, thank you both so much. And Gabe, during your presentation, you mentioned about looking at signs, especially lab values.
Yeah.
And I guess this is for questions for both of you. Have you noticed any association with eosinophilia at all?
I haven't checked for eosinophilia. What I have seen is that, some of them depends on the acuity of the presentation. The more acute, you're going to see elevated white blood cells, and then you're going to maybe see a pattern of neutrophilia. And then one of the things I have seen is that the procalcitonin tends to be negative, and the inflammatory markers could be positive. The CRP and the SED rate could be something positive. It's just going to be something, you should just look for something that looks like chronic inflammatory, like syndrome, like anemia, elevated thrombocytosis, some like not really impressive leukocytosis, but there's something that makes you think that there is some inflammation. I haven't seen particularly eosinophilia, like something remarkable to make me think, oh yeah, this is like something that I will add on my pattern recognition software to see if there is possibility of a fungal infection. Not really.
You did mention the thrombocytosis though, and
Yep.
I see that as well, particularly as they're improving. I see the same thing in people that had pneumococcal pneumonia that got effective therapy, and it's sort of an acute phase reactant, I believe.
Yep. And hyponatremia sometimes, low sodium, if there's anything that can have lung disease can give you some component of hyponatremia.
Great. Okay, it looks like we're about out of time, but I know there's some questions remaining. And so I think a lot of the questions have to do with therapeutic drug monitoring. So that might be something we may consider doing webinar on or education session on in the future, because I think it's really important as we of course want to address misdiagnoses, which is a first step. But even if we address the misdiagnoses, we get them on the right drug. Do we have the right amount of drug in the body? And I think it's really important. But I want to thank you all for coming out today. I want to thank our speakers and our fungal experts, Dr. Robert Bradsher and Dr. Gabe Vilchez. Thank you both so much for sharing your insight, your experiences, and thank you for being on the front lines of addressing these fungal diseases. And thank you for raising awareness to hopefully we can improve testing practices and just raising awareness of endemic mycoses. So Bob and Gabe, any last words today?
Yeah, we're both fun guys, but those are fungi that we're treating.
Yeah, that's that's exactly true. So yeah, definitely. One of the things that I just kind of mentioned that I was talking to Lisa is that I have used Twitter, and then some people know me from Twitter. And then I have used Twitter as a tool for learning fungal infections, and then talking to fungal experts. And then a lot of the cases that I got, I mean, I'm not such a fungi expert. I have received a lot of help. So definitely don't feel shy to kind of reach out to anyone like for help if you're dealing with a very difficult case.
Perfect. Well, I think it's a great note to end on, Bob. I think fungi treating fungis and also fungals treating fungi are great. So thank you all so much for joining us today. We look forward to seeing you all at our next session, and have a really great week, everyone.